So good evening, everybody. Thank you so much for taking time out of your busy schedule to join us here this evening at the University of Warwick MSc in Diabetes Care Information Briefing Session. Just to let you know the running order for this evening. First of all, we're going to have a brief overview or fireside chat with our Director of Academic Affairs, Mr. Dermot Brannock, and he will be talking to Jan Bennett, one of our excellent existing students on our programme. And then we'll have Dr. Colin Kenny, who's the Programme Director, and he'll give an overview of diabetes at the moment, new injectables, drugs and interventions, and just give you an overview and a sample of what you will be experiencing on the programme. And then finally, we will finish off with Dermot. Dermot will give you kind of a programmatic overview about the syllabus and about the pricing, the entry requirements and time commitments, etc. We will then open for 10 to 15 minutes at the end for a Q&A session. But hopefully we can answer all your questions in the chat as we progress as well. And don't be shy, feel free to put anything in there that you'd like, within reason. And we'd be happy to answer those questions. So now I'll hand you over to Dermot and to Jan, just to get Jan's experience as an existing student.
How you doing, everyone? Great to see you this evening, and delighted to be joined here with Janet. So, Jan, I suppose, do you want to introduce yourself to the group first, and just say a little bit your background?
Okay, thank you. So I've been a nurse for about, over 30 years now. I did old school training where you just had to have 5 O-levels to get in. Obviously very different to what it is now. I've been a diabetes specialist nurse for the last 7 years, and prior to that I was a district nurse and worked in community hospitals. I've done everything from prison nursing to end of life care, so I've got a practice nursing, so I've done sort of a bit of everything really. I absolutely adore being a DSN. I do have a daughter with type 1, and that's what piqued my interest about 12 years ago. And it was when I realised I knew more than some of the health professionals through all the intense research you do when you have a child with the disease, that it was time to take it further. So I've been a DSM for 7 years, and and here I am.
And it's really fascinating. You know, one of the things that's kind of most common when people start the program is, they've been around diabetes for whatever amount of time of their career, and they've got patients living with diabetes, and yet one of two things happen. Either they identify a gap themselves, or they come on to the program and just realize the sheer depth you can get into in the area. Which was it for you? Was it or was it both?
So my daughter was diagnosed 12 years ago, and when I started researching what was available, I realised it was actually a very poor provision really for people with diabetes. So this was I think at the time we had the old Medtronic sensors, which you could sell, you could self-fund for like £2,000 a pop or whatever. Anyway, we were very lucky and got into it, and then I got involved with Night Scout, and we started hacking things and making X strips and stuff. And I really kind of got down the tech side of it and realized that I could actually monitor my child at school. When, to be fair, most of the teachers had no idea about diabetes at all. So I felt that, it was a big safety net for us. And then I kind of, started researching more and more, and actually developed a bit of a passion for helping other people with diabetes. And
what drew you to say, right, I'm going to enroll on a master's in diabetes? What drew you to the kind of the formal side of it?
Yeah, so when I became a DSN, a lot of my knowledge was anecdotal, and I needed to consolidate that and turn it into something that was based in fact and science. And so I only actually did my BSc about 5 years ago. So I haven't actually done further education prior to sort of within the last 10 years. And I decided that I needed to underpin it. So I'm a band 7 now, and I'm involved with service development. And actually, I just thought this is the time I really need to do my master's, because I've got to look at the bigger picture. And this course has actually really helped me do that. It's blown my eyes wide open really to the bigger picture, because when you're developing services, you're not just looking at your own little locality, you're looking at almost what's happened on a worldwide trend, so that you can service plan for the future, really.
Absolutely. And it's funny you say that. The first week of the first module of this program is the epidemiology of diabetes. And when we were designing it, I kind of queried, are we going in really high level? Is it, is this as relevant as we'd like it to be? And actually, when you get into it and you start going down, it absolutely is. But how did you find the return to study? How did you find,
I was terrified, and if I'm honest, if I'd known what was involved, I probably never would have done it because I would have overthought it. But I decided to do it, and I thought, if I'm going to do it, I'm going to do it well. So I have made it a priority to get it done. And
I think the average age on the program is it hovers around kind of the 39 to 42 mark as an average age, and there are people obviously significantly both sides of that average, but it means the vast majority of people, they haven't been on an academic program for years, and how they know there's the interest in diabetes, but it's the academic side, like you say, that usually frightens people somewhat. How did you find I suppose the first essay that you had to do, kind of the lead into that side of it? Was it well supported? Was it overwhelming?
So we were given the first essay, I think, in the very first introductory week. So we had a bit of extra time than we have for subsequent essays. And actually, once you get stuck in and you've actually got that protected time to start researching it, I actually really enjoyed it, because I now know how New Zealand run their education and things like that. And it's just kind of made sense of, I deliver a lot of type 2 education. And as part of my essay, it kind of really made sense of why I'm actually doing what I'm doing, and how it extrapolates across the world, and how we're all actually doing fairly similar things, because it's proven to work.
Yeah, that's it. And I think, you touched earlier on it's the evidence base as opposed to the anecdote. And that's what a program like this gives you, is it makes sure, and, Colin is going to touch on this in a couple of minutes, that, you are absolutely as up to date on what the latest evidence is saying. And you're able to critique that evidence. You're able to go through the literature and form your own view, and look at one of the things I think is hugely important in an area like diabetes, is that you're able to look at what comes out, and you're able to acknowledge pretty straight away what the biases that might be informing that piece of research are. There's a lot of really good research. Then there's a lot of stuff from pharma. Some of it is brilliant. Some of it you have a skeptical view of. But I suppose the most important question, there's two things that I'd always focus on. One is, how have you balanced the program with your clinical, family, and I was about to say social commitments, but we've had none of those for a year.
I think that's probably helped, really. But I've actually dedicated, I dedicate half a day to it. So I know that I've got that protected time, because I think it's the same with doing exercise, isn't it? If you don't make time for it, you never do it. You have to decide you're going to make a decision and do it. And I do. So I dedicate sort of my Mondays to getting on with doing the module work. And then as the essays come out, I sort of dedicate a whole day to it, so I can sit down, because I'm a bit of a procrastinator. I'll sit there and check Facebook and WhatsApp and Instagram and do about 300 words on my essay per day, which is not very productive, but I'm getting there. And as each essay comes, I'm actually feel like I'm getting better and better at writing them.
Yeah, and
because it's practice.
So I was going to say, I think, the pattern that a lot of people seem to have is, they'll say, right, I'm going to block off a Sunday morning, or I'm going to block off, it's going to be a Tuesday and a Thursday evening, or whatever it is. They'll pick fixed time periods, and they'll say, right, family, friends, just this is when I'm going to be locked in a room studying. And it also means it doesn't seep into the rest of your life, which, that balance is really important. And, I think one of the things people will see in a while is, it's been designed, A, to be online from the outset, but B, that everybody in the program is a clinician. And with that average age group, most people in the program have kids that they're, sending off to school or uni or whatever it is. So, it has to work around people that have really busy lives. I think the most important part though is, has it changed your patient care? Has it changed how you're dealing with people with diabetes?
Oh, crikey, yes. I knew nothing about retinopathy before I start this course. And now, because my job is very glucose orientated, so I tend to just address the HbA1c and whatever. Whereas now when patients come in, I can explain their retinopathy treatment to them. And I just feel like I've got a really good handle on every aspect when dealing with the patient. And it's so lovely because I'm also picking up different types of neuropathy, which I had somebody with like postural hypertension. So, you know, they were dropping their blood pressure every time they stood up, and I thought, haha. So I've referred them into secondary care because I think they've got orthostatic, you know, hypertension now, which wasn't even a word I could say before I started the course. So
brilliant. And you know, that you can take all the stuff around it, but that really is, you know, that's the reward for doing something like this. And I suppose I could chat about this stuff all night. I'm conscious Rebecca's going to come on in a second and to tell me to move on. What advice would you give to someone coming onto the program? If you were starting module 1 again in a few weeks, yeah, what would you do?
I would just say jump in and do it, because I had about 5 days notice before I started the course. And as I say, I'm terrified of academic work, but actually I'm absolutely loving it. And one thing else, not only are the tutors responsive, because if you email with any queries, you get an email back really quickly, but we've got a WhatsApp group, and it's so great because we're all nurses on our course, but we all come from really different backgrounds. And it's really, really great because we can all share our experiences. And we also, I think we've got really good peer support. When we're stuck on something with an essay, we never give each other the answer. We might just share a link for a paper or something. So we keep it really professional.
And there's really, and you know, we've gone to a lot of trouble to design the online experience to try to create that sense of kind of community, and it's amazing when you see it in action. And actually, you know, there's cohorts that go through this course that form lifelong bonds, and you know, that is fantastic to see. And as you say, you know, there's a huge mix in the program. The European group tends to have about 40 to 50% nurses, and then, you know, obviously lots of doctors as well. And then you get dietitians and podiatrists and whatever else. But the experience of kind of people with different backgrounds and approaching things in different ways, it's just it makes it brilliant in terms of learning from each other. So right, I am going to stop and hand over to Colin, Janet, because as I say, I could just chat here all night. But look, I think it's amazing for people coming onto a program to hear, you know, a warts and all perspective of someone that's come onto us, you know, being apprehensive but actually performing and enjoying it really well. So really appreciate your time this evening.
That's great. Thank you very much.
Thanks a million, Janet.
Yeah. All right.
Cheers.
Thanks. Bye-bye.
Bye.
Thank you so much.
Okay, Janet, thanks so much. I have been teaching Janet for the last 6 weeks, and I've learned a lot from you, Janet. I hope you've learned something from me. I've got a presentation for you this evening. As you might imagine, it's about diabetes. Can everyone see my presentation?
Yeah.
It is it's just an introduction, I suppose. And I've been a family doctor with an interest in diabetes for 30 years. I also have a daughter with type 1 diabetes, and Janet and I have been sharing that experience recently. In my presentation tonight, I'm going to give you a course overview very quickly. Together, we're going to look at the world of diabetes. We're also going to look at what's the key course content. And then I'm going to give you a very quick update on the management of diabetes. Just to give you a flavour of the course, we do follow the International Diabetes Federation curriculum. We do cover type 1 and type 2 diabetes. As you've heard from Janet, we've got experienced tutors who are both practical and academically qualified. We focus what's important in your region where you are. We cover modern management. You'll hear us talk about individualizing care. And of course, we bring you up to date with studies and guidance. It is an online format. It's flexible to where you work and when you can. You can participate from your office or your place of choice. We've got weekly recorded tutorials for interaction and motivation. Let's together look at the world of diabetes. This is a leading article that I've used for a while now. Diabetes in this driver, the largest epidemic in human history, was a leading article from a very well-respected Canadian endocrinologist a couple of years ago. But of course, it's slightly been superseded now by COVID-19 and diabetes, unveiling the interaction of the two pandemics. And just to say, if you had well-controlled diabetes and got COVID, you did an awful lot better than people with poor glucose control. And I'll come back to that in a little minute. It is indeed a global epidemic. We've got 463 million people living with diabetes. A good proportion are in low and middle income countries. When you get to over 65, about 1 in 5 of the population have diabetes. Most healthcare systems spend about 10% of their healthcare systems on diabetes. Of course, don't forget children, 1.1 million children living with diabetes, both type 1 and type 2, and then pregnancies as well. We cover all these things, of course, in the course, but pregnancy is particularly relevant and important. Global inactivity certainly seems to be driving a lot of this type 2 diabetes, not type 1, and it partially explains it, along with the explosion of high carbohydrate food. So let's look at the key course content together. I teach a lot in the Middle East, and I use this metaphor of a line in the sand, but the line in the sand is 48 millimoles per mole, or 6.5%, is the cutoff point to diagnose diabetes. We'll tell you why that is. We do tend to follow the ADA standards of care. Not that they're any superior to, say, NICE or SIGN. It's just that they update them every year, which is very useful. And the algorithms are updated every year. And of course, we teach from those standards. I think NICE is going to revise their algorithms this year. And of course, we'll be bringing you up to date about that. That's in module 2. Of course, you would expect we cover oral medication, naturally metformin, but then the 4 other commonly used agents after that: DPP4s, SGLT2s, pioglitazone, and sulfonylureas. I mean the oral agents, because we also, of course, as Janet has already told you, cover the injections, insulin and GLP-1s. Now, insulin's got its 100th birthday this year in April. It's a very moving story, the insulin story. If you've heard it, and of course, if you've got a child with it, it's wonderful. There are barriers to injectable therapy. We tell you how to overcome those barriers. But essentially, they're about the right people, the right insulin, the right dose at the right time, the right strength, and the right device. And you'll get your head around all that in module 2. And it's, as I say, it's a wonderful story. Of course, we tell you where all the rest of the common agents work as well. This is a complex slide. I'm not going to go into it in detail, other than to flag up it's important that you know where they work and how they work when you come to deal with patients. Targets are a contentious area. Different organizations feature different targets, and in this case you can see the variety of targets. What we would tend to say in the UK is, based on individual patient characteristics, preferences, potential side effects and costs, we negotiate with the patient, and that's important to us. So helping patients living with diabetes to set goals. We talk about this in module 3, but essentially you start with the problem, you develop a collaborative goal, and then you validate their goal and plan. Or in other words, no decision about me without me is how you inform patient choice. And this would be very much a mantra we would follow in diabetes care, and we go on at some length in module 3 about this. The reason being is, if you look at this pie graph, you definitely need to have an expert patient. Because people living with diabetes spend 3 hours a year with a healthcare professional, During COVID, it's been much less. It's often online, of course. And for the remaining 8,757 hours, they have to manage this complicated condition themselves, which is why we encourage an expert patient. We're very careful with our language. You'll notice that both Jan and Dermot talked about people living with diabetes. They're not diabetics. That's not acceptable. But we also need to be very careful not to stigmatize the person living with diabetes, but walk alongside them in their care. Emergencies form an important part of our curriculum, but of course we'll tell you how to recognize hypo and hyperglycemia. Any of you that worked in A&E units will be very familiar with this and how you differentiate. But you know, we heard Jan say she worked a long time as a practice nurse. Here's a 67-year-old, he's had diabetes for a long time. He comes in and shows you this foot. Well, it's painless. He just wonders about the black spot on it. Certainly I wonder a lot about it. He's been walking on that sole of his foot for a while. You can see the callus. You can see a red area here that's worrying me a lot, but particularly this black area, you have absolutely no idea what's going on behind that. And I would put it to you that this is a same-day referral to secondary care as an emergency, just as a hyperglycemic episode might be as well. Of course, in Module 4, we cover microvascular complications, the opathies that people talk about in detail. Janet mentioned to you that she now knows how to recognize these opathies, particularly different types of peripheral nerve damage. I've just been teaching Module 5, which is the macrovascular complications, stroke, heart attack, all those problems like heart failure. We've gone into a great deal of detail with my Module 5 students just recently. We talk a lot about urine in the course because we emphasize how important albuminuria is. Remember, you might have somebody with CKD, say 48, doesn't seem too bad, but if they have albuminuria, they suddenly go into a very high risk category. And we need to explain to you how you diagnose and manage nephropathy. So that's our key course content. Then just want to give you a quick update on the management of diabetes, breaking trials and so on. You can't get away from COVID, I'm afraid. I've already mentioned to you, it's caused, if you have poor metabolic function and get COVID, you're in trouble. But if COVID and you get COVID, it can also precipitate ketoacidosis and hyperglycemia. Mortality is much more related to with diabetes, and then the SARS-2 virus can precipitate type 1 as well. This is a mortality graph, and you can see that once you get into an older age group here, particularly with type 1, you can see how much mortality increases with COVID. Also, if you're metabolically compromised, you need to address these areas actively in people with COVID. And of course, we've all discovered in the last 6 months, all these individuals need to be actively immunized. Moving on to a slightly different area, we're quite intrigued by this Emperor trial because it's on the SGLT2 class in people who didn't have diabetes but did have heart failure, and we've now discovered that this is also a new treatment for heart failure that came out of the trials. DIRECT is very interesting. It's something that's been going on in Newcastle and Glasgow for several years now, but they have demonstrated in people living with diabetes, if you can manage to achieve a greater than 10 kilogram weight loss, you have a very good chance of putting these people into remission, which is why I'm sure none of you read the Daily Mail, but it's led to this headline, soups and shake diet on the NHS to reverse diabetes. And yes, it looks as if this is going to be included in treatment now. This is roughly my working lifetime. What I've seen in that time is all these new agents that have come along and all the emerging evidences that's come along. Of course, I'm not going to go into it tonight, but I've lived through a lot of this evidence and position statements. These are the cardiovascular outcome trials. If you ever go to a diabetes meeting, you'll hear all about them. They've all reported now recently, all very interesting trials. And by and large, these newer agents have been very positive for cardiovascular health, I think in simple terms, as well as being effective agents. But the surprise has been the positive effect on cardiovascular health. It's led to new guidance. There was 2018 guidance. The most latest guidance is 2019 guidance, which I'll talk you through very briefly. If you look then, we're back to the ADA algorithm for this year. Very simply, metformin's always first, but if you've got cardiovascular disease, you can get a GLP-1 or an SGLT2. If you're in heart failure, SGLT2, as I mentioned, is best. And if you've got albuminuria and CKD, GLP-1 or SGLT2. If you want to minimize hypoglycemia, that's your 4 agents. If you want to maximize weight loss, that's the agents. And if cost is a big factor, then that is the agents that you use. Now, that's a very complicated algorithm to put up. If you join the course, we spend all of Module 2 talking you through that algorithm and what it means. And I've explained that to you already. So that is it. That is a very quick whiz through what we do in the course. The challenge is that diabetes care is changing a lot. I hope I've left you with that impression. It's changed massively in my working lifetime. I think, as Janet said, she was very aware that she was delivering diabetes care, and then she wanted to be forced to keep up to date, is what I got from Jan. And she's absolutely right there. You can't deliver diabetes care without getting, I feel, some sort of qualification in it. So we offer the solution at Ihead and the University of Warwick. We offer a comprehensive, convenient way to update your knowledge and skills. We ensure materials are relevant and updated, and Dermot will tell you that we just spent quite a long time updating our course. It's only 5 years old and it's been actually actively updated. We hope to develop your knowledge and skills, and we support you with technology, learning and motivation, which is what Dermot's about to tell you. Remember, sitting's the new smoking. Get up and take a little walk around ahead of Dermot telling you what to do. If you've got questions that have emerged from that, I will share them on chat, but do listen to what Dermot has to say just now about the course in general.
Thanks a million,
Thank
Colin.
you, Dermot.
Thanks a million. That was great as always, Colin. And you know what I always get from Colin's talks is just, and it's the point I was making to Janet earlier. The depth that you will go into in diabetes is phenomenal. Obviously, we will take a year to go through that content in depth and detail, but there's just it's ever evolving, and there's such a richness that you can get into. Not to do death by PowerPoint this evening, but I am going to share screen, and what I'm going to bring you through now is just an overview and the structure of the program and kind of everything you'll need to know to enroll. So one of the first things you'll notice is you'll see the name Ihead alongside the University of Warwick. And just by way of background about who we are, Ihead is an Irish company. We're a division of the Cambridge Education Group in the UK, but we were set up by a family doctor in Ireland in 2013, really looking at developing capacity, particularly within family medicine, for healthcare ministries in Europe, Middle East and Asia. And all we do is online postgraduate education in healthcare, and that is everything from residency programs through to master's programs to short course and CPD. In that time, we've had 400,000 course completions on our online learning environment and with our faculty. So it's something that over the years we've gotten quite good at. The University of Warwick needs little introduction. They're ranked 8th in the United Kingdom. They're ranked 62nd in the world. So, an extraordinarily prestigious institution. In the UK, they're a member of the Russell Group, and that is that's the top research orientated universities who really, when we look at how do the bodies of knowledge around various subject areas get enhanced, it's through the work of these universities that lots of that happens. They're renowned for diabetes education. They're one of the main centres of diabetes education in Europe. They've had 14,000 graduates in the last 15 to 20 years on their diabetes programme. What is important, I think, the qualification that you get, it is a University of Warwick master's qualification that is the exact same as any other master's program that they run. It doesn't differentiate anything because it is delivered online. It doesn't differentiate anything because it is delivered with Ihead. It is the exact same qualification as if you were to study on campus. However, the benefits of online means that we can do an awful lot more. So, the first thing I think that you'll see in a difference is actually the faculty that we bring to this program. So, Colin is an examiner for the RCGP. He's a past chair of the Primary Care Diabetes Society. Katie Reid spent her career in the University of Manchester, and along with public health, is a specialist in behaviour change and motivation and patient empowerment in the context of chronic disease management. Diarmuid Quinlan is the National Diabetes Lead for Ireland. We also have the National Diabetes Lead for Scotland on the programme. We've got the Director of the Primary Care Society in Australia, Ralph. Pam sits on the NICE Guidelines Committee for diabetes. So, what we're bringing is not just all the prestige of the University of Warwick, but actually a very international faculty. We've got probably the most preeminent endocrinologist in Malaysia on the programme. We've got one of the heads of diabetes care in the Dubai Health Authority. So we're getting perspectives from absolute leading lights in diabetes from all over the world on the program, which is phenomenal. As an online program, one of the things that can differ is, how does this look and feel to me participating in the program? So, the first thing is, just because it's online doesn't mean that it is, one of these massive open courses. It's ran in small groups. There's about 20 people in each group. So, like Janet was saying, she's gotten to know her group really, really well, and they make lifelong connections on the program. You get to know your tutors extraordinarily well. They get to know you. So it's it has all the benefit of small group teaching. The modules, and I'll go into the modules in a couple of minutes. The modules are structured extraordinarily well. They are, the taught modules are 6 weeks long each, and then you have time for assessment. And that pace it's been designed that everybody in the program is a busy clinician. And I think it was Joe was saying in the chat about, being able to make it in time for tutorials and things like that. The very DNA of this program is online education, and everybody is a part-time learner and a full-time clinician, and usually with a small family in tow as well. So there's a lot of flexibility and support built into it. We've had over 500 students on this program since we relaunched it in 2019 in this iteration of it. And, every single one of those is a busy clinician, and they, the pass rates, the satisfaction rates, the support levels, everything shows that format and the supports that we have work. The the amount of support and guidance you get on the program is huge. I mean, Janet spoke about her tutors getting back to her really quickly. You will meet one of the program management team from Ihead on every single one of your tutorials that you have. So, you know, there's always someone to ask the question of, there's always someone to raise a concern to. And we use a lot of the analytics that sit in the background of the program to see, you know, what are people engaging with, what are they struggling with, and where do we need to offer more support. So it's a really, really well supported program. In terms of what you'll actually study then, so the master's is broken into 3 semesters. Semester 1 is a postgraduate certificate, semester 2 is a postgraduate diploma, and then semester 3 is the master's. What you cover then, as Colin said, you know, we look very carefully at the international guidance on what diabetes curricula should cover. And then we looked at, you know, in terms of structuring this, the patient journey with diabetes seemed the most sensible to us. So we will start off looking at core principles and very much, you know, finding and diagnosing our patients, and really get starting off with, you know, a really good grounding in evidence-based medicine, and, you know, what is the evidence pointing us towards. And, you know, as Colin said, this is a space that's constantly evolving and constantly moving, and making sure that we're up to date with the latest evidence is key. So, you know, we look at screening programs, we look at the prevention of diabetes, and then we move on in the second module, and each of these are representing the topics in each of the 6 weeks that you'll cover. We move on to self-management, and, you know, as Colin was saying, the impact that diet and lifestyle can have on somebody with diabetes is phenomenal. So to achieve the best results you can with that, you need to have a toolkit that you can draw from to empower your patient. So, you know, how to do motivational interviewing properly, the psychology of why people will resist change, or actually, you know, nudge theories to what will make them more likely to have lasting change in their diet or their lifestyle. The importance of physical activity, how they, you know, the patient will be living with diabetes, you know, and they need to be able to monitor themselves. They need to know what to do when they get sick days, and they need to know what to do when they have acute complications. So the second module very much focused around, you know, patient self-management of their condition. And then the third module we get into is treatment. And irrespective of your scope of practice, which depending on your profession or depending on where you are based may well differ, we will be giving you the entire range of therapeutics that are currently available in diabetes. So, you know, we'll go into why different treatment options are there, and then we'll spend quite a lot of time across all the various drug treatments that are there. We will then look at insulin in a lot of detail, and then surgical treatments for diabetes. We'll also look at the differences between diabetes in children and adolescents. So you get a really, really comprehensive overview of treatment in diabetes. So that makes a very coherent first semester of, you know, you're finding your patients, you're helping them to manage their condition better, and you're getting really in depth in treatment. When we move into semester 2, then, as Colin said, you know, we're dealing with complications, and, you know, we're trying to mitigate them, but we're also managing the impact of them. So we're looking at small and large blood vessel complications for modules 5 and 6. And, you know, that's everything from eyes, feet, kidneys, foot care, big focus on cardiovascular risk prevention, as you'd expect in the program. And then Module 6 really gets into some quite specific areas. So gestational diabetes, how do you manage someone who's fasting with diabetes? How do you manage someone that's playing, you know, lots of sports? What does that exercise do to their sugar levels? How do they adjust their treatment for that? When we used to have international travel, you know, if someone travels 6 hours east or west, what does that do? There's a huge body of literature on the you know, the link between diabetes and mental health issues, and we explore that in quite a bit of detail. people are living longer with diabetes, which is fantastic, but that means that we now are managing diabetes with lots of comorbidities as well. So you can see across the first 2 semesters, we've got, you're very much following the patient journey, and you're getting into quite an amount of depth in each area. And the six-week modules is a really, really nice structure to work with. When you go into semester 3, then for people that go on to do the full master's program, this is where you move from everyone following the same path to you choosing an area that you want to get into in depth. So you pick something, and it could be referral pathways, it could be a particular drug treatment, it could be a service evaluation, it could be a systematic review of the literature on mental health and diabetes. It's whatever area interests you, that you think I can ask a new question here, or I can look at something in my context because it was previously looked at in the US or the Australian context or whatever it is. And so you find your research idea, you find your research question, you review the literature, you design your methodology, and then you get a proposal through academic and ethics review, and then you go off and you do the project, and you work with your individual supervisor, and you collect your data, you analyze it. And I think what Warwick do in terms of the output of the master's module is phenomenally innovative. So instead of a thesis that will sit lonely on a shelf unread by many, you'll do a journal article and a conference poster presentation, and something that is actually of utility, and that the first group that came through the master's program are now starting to put their work forward for publication. And that's amazing to see, in terms of that you get such a tangible career benefit from the program as well. So across the 3 semesters, the PG Cert, the diploma, and the master, you get a really comprehensive view of diabetes, the confidence in which you will treat patients. And that's something that I think came across in Janet's talk extraordinarily well, that just the depth you go into, the confidence that gives you is phenomenal. But actually, what does this look like on a weekly basis? So what does it feel like to go through one of these modules? So the first thing is, we will start off with a really comprehensive orientation. So the induction week that we have, as I said at the start, the average age in the program is in the 40s, and everyone is a full-time clinician. So it's quite a while since people have been studying in this way. So we make sure you're comfortable with the supports that are available, with what our expectation is, with how to use the online platform. And sort of before you start week 1, you have everything you need, and you've had every opportunity to ask every question that you have. So that induction week is really, really important, and gives you a great deal of confidence going in. Every week then follows a pattern. So we'll start each week with a discussion forum, and that will be a case vignette, and that will describe a patient with, so I come into your clinic, and I'm complaining that I've a pain in my calves when I walk particularly quickly, and what would that lead me to want to investigate? What would the next steps be? And you discuss that online with your colleagues throughout the week. Each of those cases is linked to the week's topic. So if we're dealing with peripheral artery disease, for example, you'll have the weekly discussion forum that'll be a case on that. You will then bring yourself through the online content in your own time during that week. So, and the quality of the experience online is absolutely phenomenal. As Colin said, the material is all absolutely up to date, but it's also some of the best e-learning material and best online experience you will get in medical education, full stop. It's really interactive. It is full of kind of visuals and imagery. And as you can see here, this is a video describing how retinopathy happens. I've got the volume turned down. It really, what we get into is patient cases, and you will learn through patient cases. So we'll give you the background and the pathophysiology and all of that, but then we'll get into patient cases, and you'll do simulations, and you'll really get to the heart of clinical decision making. And as we've said a lot the whole way along this evening, the coverage is really, really comprehensive. So what you get is this really immersive, really interactive learning environment that at any stage during each week, you bring yourself through that. So you do your discussion forum, you go through the online content, and then towards the end of the week, and in Europe, it is usually a Thursday evening, and we usually have 3 groups. So we'll have weekly tutorial sessions that start 7:30 and 8 p.m. There's tutorials on a Friday morning, very, very early on a Friday morning at like 7 a.m. that some people in Europe are opting for, because they do their tutorial before they start their day's work. Similarly, there's lunchtime tutorials on Thursdays, but they're not as popular. But there's lots of options as to when you can attend that tutorial. Everything is recorded, like tonight's session, everything is recorded. You'll get sent it afterwards, so you can go back, and anything that you miss, you can catch up on. The assessment is, again, it's really fair and balanced, and I think linked to your professional practice. So what we will ask you to do for the assessments is, we'll say, review the literature on diabetes screening tools and say how they may be relevant to your clinical setting. So everything will be, get familiar with the content, get familiar with what the latest evidence says, but actually then, think about, how will I apply this? How is this relevant to my context? So, and the whole focus of this program is to enable better clinical decision making. And that level of detail of examining what the evidence says and how I will apply it is fantastic. The exam is really straightforward again, and the exam is going to be look and feel very like the weekly discussion forum cases that you get. It will present you with case vignettes, and you'll simply you're saying what's the next step in diagnosis, in treatment, in referral, etc. And what you'll see in a couple of minutes is that the assessment is not something to worry about. The pass rates on the program tend to be very high. Everyone coming onto the program is a qualified clinician. We have really, really good engagement levels, and the assessment is set fairly. So you expect most people to get through the program. There is a huge amount of support that I referenced a few minutes ago. So Stephen Lawrence and Colin as the program leaders. The tutors are, they are a bunch of incredibly enthusiastic, motivated people who are passionate about diabetes education. And, they're from all over the world. You'll have a mix of tutors from the UK, from Australia, from the Middle East, all of them absolutely expert in their field. As I said, the program management team you'll meet every week. So you'll see one of the academic affairs team every single week on every one of your tutorials. The tech support people are there in the background. There are rarely issues that people need to call on them for. I suppose the experience then. So as I said, we've had over 500 students on the program in the last few years. There is 88% average student engagement, and that says a couple of things to me. One, for busy clinicians, it's pretty high. It's rarely the same people missing lots of things. It's but everyone will miss a couple of things, and that's fine. And when I look at that in conjunction with the pass rate, it says that it's also okay to miss a couple of things as you go along and still get through the program without any issue. And we're amazed at the level of feedback that we get on the program support, on the assistance that is given. People feel really part of a community, and they feel really supported as they go through it. We do pre and post surveys. And this is after the second semester that this data comes from. So what we look at is, before people start the program and afterwards, what's their confidence level in various aspects of diabetes care? And this is asking people, rank this on a 5-point scale of extremely confident to you've no experience doing this. And, you can see here things like helping someone overcome obesity, that's still going to be challenging, but the clinical decisions, like cardiovascular risk prevention, putting people on injectables, that type of thing, absolutely, people come off this program really, really confident in what they're doing. We went back last year to the group that qualified in 2017, and we said, right, you're 3 years out. What has this program meant to you? And again, you can see here, patient care, career progression, reputation with your colleagues. And one of the things that often comes off the program is, you get a reputation for seeking out the complex, challenging diabetes cases. You find those patients that have been a challenge, and you do good things with them. We also ask them on career outcomes. Where is this led? So you've got the GP with special interest in the UK. Lots of people are managing diabetes clinics, especially in the Middle East. Lots of people have gone on. They've used the program as the academic qualification for becoming a diabetes nurse specialist. We have alumni that are sitting on national diabetes strategy committees, and that level of thought leadership is phenomenal to think that it came from the program. People are involved in diabetes education, obviously, people in podiatry and nutrition, etc. And then we have people that are working in pharma. So, there's a huge range as to where you can go. Aside from, I'm going to deliver a better quality of patient care, actually there are, very tangible career benefits to the program. So, and I see a question about spaces coming in. As I said a couple of minutes ago, it is an online program, but the tutor to participant ratio is extraordinarily important. The small group learning environment is extraordinarily important. So we take on usually 3 groups in Europe every time we run it, and then a group in the Middle East and a group in Asia Pacific. So that puts a cap on how much we have. This far out, it's usually about half full at this stage. So in terms of criteria to join then, so it's pretty straightforward. Health science degree from a recognized institution. Conscious there's a lot of nurses on the call this evening. There is an application route if you are a diploma holder. If in nursing, up until a few years back, degrees were not the career path. So if you are a nurse with a diploma that would like to join the program, just get in touch with the education team and they'll guide you through that process. It is really important. What I hope you've seen from this evening is the patient management focus of the program and clinical decision making. So you do need to be seeing patients with diabetes, and obviously then the program will be conducted through English, so you need to be able to complete it on that basis. That is not an English language test if you're from somewhere other than UK or Ireland. What we will do is the education advisors will be speaking to you, and we will ask you for a personal statement, and that will give us enough comfort as to the standard of English that you have. What we'll ask you for, and it's a totally online application process, we'll ask you for a copy of your degree, the personal statement, an employer or an academic just to say that you're a clinical professional in good standing, and we'll ask you for photo ID. So really, really straightforward application process. And the criteria, as I said, are, it's just, the program is designed for the broad interprofessional team around a patient with diabetes. So, it's what we get are everything from doctors, nurses, podiatrists, dietitians. You'll get the occasional cardiologist. You'll actually get the occasional endocrinologist coming on it. But it is a broad health science background is what's needed. So fees, which is going to be the next thing everyone's going to be interested in. So The MSc is 12,000. The postgraduate diploma is 8,000. There are significant enough bursaries or discounts available if you apply and if you pay early. So there are, you can see there, you can take the cost down quite substantially. Those offers are available until the end of this month. So they encourage early registration, and the reward for doing so is quite significant. Once you're paying fees, obviously you can pay up front, you can pay by semester, and there's monthly payment options, and the education advisors will walk you through all of those options individually when they speak to you. It is eligible for Student Finance England as well, for those that are in the UK that might be relevant for. So that is pretty much everything I was going to cover this evening. I'm conscious of time, of 1 minute left. So it's a 22-month program that's split into 3 semesters. A 6-month postgraduate certificate, a 6-month postgraduate diploma, and then a 10-month master's. The next intake is the end of October. It is filling up extremely fast. The autumn intake is always the most popular one. What you get in terms of coming off the program, Warwick are renowned in diabetes. They're a top 10 UK university. It's recognized worldwide. You get the academic award. You also get CPD for it. The program, what hasn't come across enough tonight and never does, is the fun, the camaraderie, the lightheartedness with which the program's run. It's a bunch of really enthusiastic people that love diabetes and love education that you'll be dealing with, and then an entire team of educationalists supporting you as you go along the way. So it's the satisfaction rates that we get, the referral rates that we get, they come from people having a really positive experience. So it's a really, really fun, in-depth exploration of diabetes that makes people a lot more confident and competent in managing patients living with diabetes. So I will stop screen share there, Rebecca, and see what have I missed on chat.
Thanks, Stuart. I think the team have been answering the chat as we progress, which is great. Lisa Calder there just asked if she's a diploma holder nurse. You did cover that, which should be eligible. But we do have a route, Lisa. You do have to do an additional interview with one of the faculty members in the University of Warwick to just go through your learning outcomes and how they equate in terms of RPL to get onto the program, or recognition of experiential learning. But you do have an entry route, and it involves an interview. Just to let you know, guys, it has been quite a nurse-centric webinar this evening, and that's wonderful. But we do pride ourselves, the Ihead and University of Warwick programs are interprofessional. We have a wonderful mix of the full transmural care team, from doctors, specialists, dietitians on the diabetes program, pharmacists, and what we find works extremely well has been educating the full medical intervention team together, and those handling particularly long-term and chronic disease management. If you work and are educated as a cohesive team, you have far better outcomes and a far better impact and an understanding of each person's role and each profession's role in the caring for long-term diseas.
There's some really good questions coming in the chat at the moment, actually. So if you can you apply for a diploma and then kind of carry on to the MSc if you want? Absolutely, 100%. There are 3 exit points. Virtually nobody leaves after the first semester. About 50% will do the full MSc. About 50% will just do the postgraduate diploma. And
just let you know, though, you won't get Student Finance England for anything less than a master's, and you can't exit with the PG dip. If you look for Student Finance England, you have to go all the way to
full MSc. And it's funny, the number of people that are doing the full MSc is growing each year. It's the group that are literally finishing now, about 60% of those are going on to the MSc. There are 2 exams. There's an exam at the end of semester 1, and there's an exam at the end of semester 2, Agnes. They are They'll cover all of the modules in semester 1 and semester 2. The exams are all based on case vignettes of, patient comes in, these are the symptoms, what do you do next? There's no numeracy or statistics exam involved at all. If you go on and do the MSc, and if you do if you do something that is going to involve quantitative analysis, you'll get into statistics at that level. That said, there are plenty of people that do projects for their MSc that don't touch statistics at all. So there doesn't have to be any if you want it, and if you do want it, you can go absolutely mad in your MSc and fill it full of statistics, whatever your preference is. What else is coming?
Joe, there will be an intake. There's 2 intakes per annum in the spring and autumn. So there will be another one in the spring as well.
Yeah.
And we will have early registration discounts at that time.
So pediatrics, what you've probably got from the talk this evening is the focus is primarily type 2 diabetes. We do cover type 1 in quite a bit, but not, it's not as in-depth on pediatric diabetes. We have a couple of specific masterclass sessions on it, but the focus is probably more on adult diabetes, is fair to say. So we have had people in pediatrics come through it. They've really enjoyed it. But I wouldn't want you under a false impression that it's heavily focused on kind of type 1 in kids. So yeah, the essays, the essays are really, they're reasonably short as university essays go, and you can segment them quite a bit. With the essays, you end up kind of writing, well, I'll do 500 words on this and 500 words on this, and they come together quite well. I thought one of the things Janet said, she's approaching her 5th essay now and feeling way more confident than her 1st or 2nd essay, and we see the grades going that way as well. No one's module 1 essay is as good as their module 5 or 6 essay. It is a journey. People are understandably nervous at the start, but the progression and the development is huge. What else have we not seen on chat?
I think we've covered and answered the guys. The team have been answering questions.
Brilliant.
And Colin has as well. So hopefully we've answered them all. Just to reiterate what David said, guys, we don't, just because it's an online program, we don't enroll and register with impunity. We do have caps. We want to make sure that each one of you that decides to participate in the program has an excellent one-to-one and a close relationship with your colleagues, peers, and your tutors. So we cap it at 30 per cohort in a group size, and then we might have 3 of those groups over Europe, but we never go beyond that. So we don't register with impunity, and those places are filling very, very fast. But I would say, if you are interested, please progress to application and deposit payment to secure that quite significant discount by the end of that month, if possible. If you are going to be sponsored by a trust or a CCG, we do ask that you pay a deposit, and we will refund, just to secure the discount price, and we will refund that deposit as soon as your trust or your CCG or your employer pays for the program on your behalf, and we will refund that in full. But the deposit is just to secure your place. What I will say is we will be sending out the recording of this webinar to you, and you'll receive that by email tomorrow. It will also have a link to apply and to register for the program, and our education advisors will be reaching out to you just to ask if you have any other queries, if you need help or assistance with the application process, and if you want to progress. So you will be getting a call from them in the coming days. So just keep an eye on that.
Brilliant. Thank you so much, everyone. It was great to see everyone this evening, and hope to see lots of you on the course.
It's a pleasure to have you here tonight. Thank you for taking time out, guys, and hopefully we'll see you very soon.
Thank you so much.
Take care. Bye.